my mother through childhood and through most of my adult life. And I want to emphasize, we are not just in the business of birthing babies. We're in the business of ensuring those babies have healthy mothers throughout their lives. And I would, as a clinician, I'd like to give you an example of a patient I looked after this week. She'd had 3 previous pregnancies, 2 previous miscarriages with D's and C's. At 28 weeks, she went into preterm labor. She was transferred to Mount Sinai Hospital, where she had a spontaneous vaginal delivery with no issues. She was transferred back to our hospital as her baby grew, as she was no longer an inpatient, but her baby came back to our nursery, and she was in the nursery looking after her baby, when on Tuesday morning, she suddenly started to have massive vaginal bleeding. She was now 4 weeks postpartum. We were able to rapidly stabilize her, and she had an ultrasound that morning. I was called by the radiologist, who said to me she has no retained products, but she has an arteriovenous malformation in her endometrium. And essentially that is a condition which is treated by embolization. Within 2 hours at the general site, this patient underwent embolization of her AV malformation. She was, by supper time, able to have her supper. Her bleeding had completely stopped. Although she dropped her hemoglobin from 124 to 70, she did not get blood products, she did not end up in the ICU, and she did not get transferred. And this is what I'm talking about. We need, in a busy obstetrical unit, to be ready for those rare occurrences where young, healthy women can become extremely ill. And I want it emphasized to my colleagues at the Birchmount, I am in no way trying to diminish the excellent work they do there, the excellent low cesarean section rate, high VBAC rate. I'm talking about the issue of the rare occurrence where we have an extremely ill mother. Now, have I got this right? And when you're talking about that, we need to go back to the worst, to maternal mortality. And this is a graph of maternal mortality all over the world. But if you look to the pie graph in the bottom right-hand corner, we're looking at developing countries, and I want to really concentrate on bleeding, because postpartum bleeding is probably the one thing in obstetrics that we can control, we can prevent deaths, and good, rapid, early intervention is of extreme importance. And I note that in developing countries such as Canada, we still have a 13.4% of maternal deaths are due to hemorrhage. If you look at maternal deaths in Canada, they range from a low of about 6 to 10 per 100,000. It is a rare event. But if you're saying 13% of these numbers, you're talking about 5 to maybe 10 women a year in Canada who are dying from postpartum bleeding. And if we go on and look at postpartum bleeding, and sometimes just looking at death rates is difficult because, and I'm very proud to live in Canada where we have such a low maternal mortality rate, but we still have a severe morbidity rate of almost 14 per 1,000. And we have a rate of atonic postpartum hemorrhage at 29 per 1,000. That's 2 to 3 per 100, all right? If we're doing 400 deliveries per month, that could be as many as 8 per month. And one might say, well, with good obstetrics and modern interventions, postpartum hemorrhage should be on the decline. It's not, it's on the incline. This is a study from Australia, but there was a similar study conducted by Tom Vosket in 2007, looking into increasing, the reasons for increasing postpartum hemorrhages in Canada as well. And then one might say, well, we're going to have this big unit, we're not going to put in place interventional radiology, we don't have a high-level ICU, we have an operating room that does basically outpatient surgery with anesthesiologists who are working largely with outpatient low-risk surgery. So therefore, let's try and identify those patients who might be at risk and get them out before the problems happen. But sadly in obstetrics, and I look to Nick, we know that many of the women who get extremely sick have no risk factors. And if you look at the Ontario Coroner's Report from 2010-2011, in Ontario there were 31 maternal deaths. And of those, 30 out of 31 were 32 weeks or greater, so they would not have been transferred based on gestation. Only 2 of the women had a serious pre-delivery medical condition. Again, none of them would have been identified prior to the time of delivery. And in fact, 27 out of 31 of these women who died had no identifiable risk factors, meaning that in Ontario, we're looking at maternal deaths in women who come in as healthy, normal women with no prior medical issues. So I want to emphasize, I have tried to emphasize through all of these deliberations that yes, I'm proud, I'm an obstetrician, good obstetrics matters, but good obstetrics doesn't happen in a vacuum. We can't give safe care without excellent, in-house, high-level ICU, closed ICUs. We need, and we find more and more the importance of interventional radiology. Not common, but when you need it, it is not only life-saving, but fertility-saving. We need anesthesiologists who are used to looking after critically ill patients in the OR, who are used to massive blood transfusion protocols, who work critically, okay? And in that same vein, we need to be supported by a full-service operating room, an operating room that is used to doing major cases with sometimes massive blood loss. And you take away any of those issues, you take away a safety net offered to healthy women. And I just want to stop and just talk about uterine artery embolization because it's one of the arguments I have had with the administration on and on through this. Because I'm told forever we don't do it often. No, we don't do it often because we practice, because of many issues, because severe life-threatening blood loss is not that common. But to just remember that when we do it, we have a high success rate. There is a low morbidity rate. We manage to preserve reproductive function. And it has been stated that uterine artery embolization is the technique of choice to control life-threatening, intractable postpartum hemorrhage. And anyone who's an obstetrician can surely understand why I would fight tooth and nail not to lose that service. Okay, so if we are now put in a hospital where we do not have a high-level ICU, we do not have interventional radiology, we do not have an OR that is used to high-level, ill, severely complex patients, what can we do? We can attempt to stabilize and transfer. And then in stabilizing and transfer, we lose the magic hour. That hour when you can stabilize patients when she's not lost all her clotting factors. We know that rapid ICU intervention will result in improved outcomes to maintain fertility and decrease blood loss. It's in the literature. The need for intensive care in women is commonly unforeseeable and unavoidable. And I'll remind any of you who has had to deal with interfacility transfers in Ontario, it is complex and often difficult. And at this point, I would like to read a letter from Professor Joseph Barrett, who is the Chief of Obstetrics and Maternal-Child Care at Sunnybrook Hospital. Dear members of the panel, I wrote originally on this matter some time ago, expressing my opinion as to why the plan to relocate maternity services to a hospital without the required intensive care and interventional radiology was a mistake. It was a mistake that I lived through as Chief of Maternal Fetal Medicine at Women's College Hospital prior to our relocation to Sunnybrook. And it is a mistake that I did not want to see repeated in another Toronto hospital. In addition, as the nearest Level 3 unit to the Scarborough hospitals, the predictable transfer to our hospital of women bleeding in extremis is something that will directly impact my service at Sunnybrook Hospital. I am relieved to hear that the decision to close the General is being revisited. Had I been available, I would certainly be presenting the folly of this relocation to the panel at the public forum in May. And instead he asked me to read this letter. An additional plan that I've heard about is to locate the obstetric unit at a site with no inpatient surgical services. This is similarly ill-conceived. The requirement for surgical support for obstetric patients is infrequent but life-saving. I'll be done in 2 minutes. I implore the panel, both as an obstetrician who cares about the safety of women in childbirth, as well as the chief of a service that will likely be called upon to care for sick women transferred to us from the Scarborough hospitals, that we do our best to ensure that high-volume obstetric unit be located in the setting of comprehensive support services, which, although infrequently needed, will save women's lives. And I just end with the words of Dr. Tom Basket. A review of pregnant women requiring critical care reminds us that it is inappropriate to reduce the vigilance and resources that assure maternal safety.
For the last 25 years. I do quality care assurance work at the college and chair a couple committees on independent health facilities, as well as other committees, both locally and nationally. We are the women's health care providers at the Scarborough Hospital. We believe that regionalization of women's and children's services is safe, benefits the community. It's practiced locally, regionally, and nationally, and it's long overdue. The distance between Sunnybrook and Martin-Sobel Hospital is 30.3 kilometers, or a 30-minute drive. And if you take the 407 and are willing to pay the $12, it actually takes 25 minutes. During this drive, one passes 6 emergency rooms, 6 obstetrics units, and approximately over 16% of the province's women's healthcare providers service these 6 hospitals. And many of them don't have interventional radiology. We'd like to thank the LHIN leadership, the hospital leadership, professional staff, the support staff that helped make this happen today, and the community members that are attending. Through science, data analysis, collaboration, and expertise, we can move forward. This is a critical time for our community, especially the women and children we service in Scarborough.
Good morning. I'm Lori Hinsett, and I've been a registered midwife for 14 years in the area of Scarborough. I'm also the head midwife at the Scarborough Hospital. This group represents midwives, community partners, nursing, family physicians, emergency physicians, obstetricians, and pediatricians at the Scarborough Hospital. Data shows that the Birchmount site is one of the safest women's units in the city. We support the strategic plan refresh and regionalization. We have a mature, collaborative care model. We are data-driven, and we have one of the lowest cesarean section rates and the highest VBAC success rate in the city. We are also proud of our short length of stay. Leadership should bring out the best in the community, be dedicated to staff, and should be proud of its accomplishments. Leadership should be successful in working with regional and government initiatives during prosperous and challenging times.
I'm just going to go over the perspective from 1997 to the present. The first review of restructuring services in the eastern quarter of the city started in 1997. Our experience from 1999 to the present, working in the Scarborough Hospital Corporation after it amalgamated, was the following. We went through, unfortunately, 6 chief executive officers and 1 supervisor. During that time, we've had numerous external reviews. Actually, to my count, at least 7. And even more internal reviews. All third-party conclusions came to the same conclusion. There's a significant loss of patients from our cluster. Some data suggests it's from 24 to 36%. In other words, 1/3 of the patients in Scarborough are not satisfied with the service that they're receiving at the current time. And we want to change that. That's what we're here for. That's the responsibility of us in this panel and at your expert panel. The loss of patients from Scarborough to other regions, and the other thing that they came through clearly on each report says there should be regionalization of women's and children's services with further investment and proper supports put in place. Unfortunately, the intransigence that's happened over this period of time has allowed us to go nowhere. The important thing around this table is that we all know good ideas, great ideas can be moved forward. Sometimes they're not as perfect as we want them to be, but as healthcare professionals, we're supposed to guide the community, we get better access, more affordable access, and better service. And that's what we're talking about today.
Thank you very much. My name is Haidar Mahmoud. I am practicing obstetrician and gynecologist in the Scarborough for the past 18 years. And I was actually the site chief for 8 years. We need the expert panel support us so that we can develop and support a safe and regionalized programs, provide linkage and backup to improve patient care and safety, help us place the needs of the community first by improving quality, access at an affordable cost. Also, we need to advocate for funding and programs for women's and children's services in a positive, knowledge-based, cooperative manner. If we think about regionalization is safe, just different. Gynecology service will be provided at all 3 sites by an integrated model. Pediatric service will be addressed by Dr. Garmat and Dr. Ragavir. Emergency service have been reviewed and will be addressed by Dr. Norman Chu this afternoon.
Hi, my name is Dr. Garmat. I am a pediatrician. I have been on the pediatric staff at this hospital, formerly the Scarborough Grace Hospital, since 1986. We decided to speak to you as a group because we believe we represent a team, the maternal, newborn, children's team of the Scarborough Hospital. And we want everybody here to understand that we as a team are absolutely committed to the best and safest care for our patients. We do as a team believe in an integrated program at this hospital because we believe it will deliver the highest quality and the most cost-effective services to the families of Scarborough. We believe there are many advantages to an integrated program, and we believe it will lead to continuous quality improvement, very important. It will help with staff recruitment in a very competitive market, and it will optimize the utilization of scarce resources. And we believe that this will enable us to expand our programs and services, that we will be able to continue to offer enhanced supports as opposed to removing support, such as happens now. Simple things like breastfeeding, nutritional support, therapy services, for which we constantly have to fight. And that ultimately, we hope it will facilitate the development of more and better programs. For instance, developmental needs in Scarborough are severely underrepresented. Our clients are not well serviced there.
Good morning. My name is Vinod Raghavir, and I'm a pediatrician and neonatologist, and I've worked at the Scarborough Hospital virtual division for the last 16 years. In terms of safety, we acknowledge concerns raised regarding pediatric coverage at the second site without obstetrics. Pediatric support and consultation services must be available in a timely fashion. A model for these services can be developed, assuming a full complement of staff. The participating hospitals in the area and the LHIN will need to play an active role in retention and recruitment. Assuming and assuring safety and timely consultation services will be focused moving forward.
Hello, my name is Adrienne Torres. I have been a family doctor in Scarborough since 1990.
What are you recommending? Which site?
We're recommending the site according to the KITS recommendations in Sunnybrook. What they recommended was, in 2006, that there be important surgical backup for a thriving obstetrical unit, and that was part and parcel of that document. So we believe that the siting should actually be at the Birchmount because the patients want an emergency room at the Birchmount. We believe that it should have the surgical supports and the linkages and access to interventional radiology that allow it to be successful.
Thank you very much.
On behalf of my colleagues, the nurses, midwives, and physicians working at Scarborough Hospital, and to thank the expert panel here for your time to listen to our input regarding the proposal for central excellence for maternal, newborn, and women's health at the Scarborough Hospital Birchmount campus. This presentation has been created with input from a multidisciplinary team of healthcare providers, including members from Department of Obstetrics and Gynecology, Midwifery, Nursing, Pediatrics, Emergency Surgery, and Family Practice. You've heard from the pediatricians from the previous presentation, and the emergency doctors, they are attending at this moment a retreat in Barrie and able to join us right now. But they will be present here later today with a presentation by Dr. Norman Chu regarding emergency care. A center of excellence in maternal, newborn, and women's health should be located where the needs are greatest, and to ensure that services are accessible by those who need them most. As you can see from this slide, there are 3 sites providing obstetrical services in Scarborough, and the TSH Birchmount is the only site located in North Scarborough. Whereas south of the 401, there are 2 sites located within 10 minutes drive within each other, so probably representing some duplication of services in that area. Now this slide, with data contributed by our community members and partners, indicate the tremendous growth and population needs, so that this growing community here needs services, quality, accessible services in the next 10 to 15 years in Scarborough. And the pink dots here indicate all the new residential units and condos that are being built and will be completed in the next few years. There are over 20,000 of these units under construction in the vicinity of the TSH Birchmount campus. For example, like 6 towers, just 1 block from the TSH Birchmount site, accommodating over 2,000 residents. On the Birchmount Road itself, there are several projects going on, including a multi-billion-dollar huge complex where over 25,000 people will be living and working. The Center of Excellence ensures that this growing community will have access to quality services and will benefit all the new families moving into this area.
Good morning, my name is Kenny Pop. I'm a registered nurse working in the Scarborough Hospital for 22 years. The Scarborough Hospital Birchmount campus, or formerly known as the Scarborough Grace Hospital, was the first community hospital in the entire country of Canada to receive a 4-year accreditation award in 1993. The hospital, with the first baby born in 1985, was always excelled in maternity newborn care. It is the hospital in the province to bring to a single-room LDRP model in 1988. So we are the pioneer of single-room maternity care in Ontario. Despite the lack of investment into the obstetrics program service since the merger of Scarborough Grace with Scarborough General in 1999, data show that our performance remained excellent, with a short length of stay, 1.5 days at TSH Birchmount, compared to 2 days at TSH General, and 1.8 days through the national average rate. Low cesarean rate of 24%, which is lower than the national average of 27%. VBAC rate at TSH Birchmount is the highest among GTA hospitals and the 3rd highest in Ontario hospitals.
Hello, my name is Adrienne Torres. I have been a family physician practicing low-risk obstetrics at Scarborough Hospital since 1993, and I have a large pediatric practice. At this point, the current population in TSH Richmond community is 380,000, and this is projected to increase to 426,765 in the year 2021. 65% are made up of immigrants. As reported by the Globe and Mail earlier this year, this area is already deemed a priority neighborhood by the city. It is badly underserviced in both community and hospital services, as recognized by community partners, including the YMCA and the United Way. As a family physician who has been working in this community for over 20 years, I testify to the growing needs for primary care services and access to hospital services. An integrated model of patient-centered care provided by a multidisciplinary team of specialists and subspecialists working closely with family physicians and community providers will ensure that this diverse community of women, children, and youth have access to safe and quality care.
Scarborough Hospital, the Birchmount site, formerly Scarborough Grace, was one of the first hospitals in Ontario to give privileges to midwives in 1997. Diversity Midwives is a group of 10 midwives providing care to women in the Scarborough area since 2001. And 2 of its members have actually provided maternity care to women in Scarborough since the late 1990s. In fiscal 2012 to 2013, Diversity Midwives attended 371 births within our practice. 325 of those were hospital births. Midwives have helped to contribute to the Scarborough Hospital's high feedback rates, low epidural rates, low cesarean section rates, and their short length of stay rate. A center of excellence would allow for an expansion of midwifery interprofessional care model. Midwives need to work in a multidisciplinary, collaborative environment. The Scarborough Hospital Center of Excellence would support women in having choice and access to obstetric and pediatric consultation and intervention when needed.
With the Center of Excellence at the TSH Richmond site, 24/7 coverage of the general site will be provided by separate gynecologists on call. Will ensure patient safety at both sites. All TSH OB gynecologists, the staff will take turn so that the calls at both sites are equal, shared, and rotated among all members of the staff. This will ensure timely management of ectopic pregnancy, incomplete abortions with hemorrhage, and other gynecological emergency to ensure patient safety. An integrated model of gynecological coverage of the hospital site in the Scarborough cluster will ensure patient safety. With intervention radiology is only one of the many components of management of postpartum hemorrhage. And intervention radiology is rarely required and will be supported by regional initiatives.
You've heard from the pediatricians for the previous presentation that an integrated pediatric model of coverage for the Scarborough cluster and Central East LHIN with a dynamic program and appropriate incentives to retain and recruit pediatricians will ensure patient safety in the pediatric population of this community. And I thank Dr. Layton for his excellent question about surgical support. Timely access to surgical and urological consultation is essential to patients in a center of excellence for maternal, newborn, and women's health due to the anatomical proximity of the uterus, bladder, and bowel to the uterus and surrounding pelvic organs. Therefore, adequate number of beds, surgical beds, and up-to-date surgical equipment will ensure patient safety and surgical support for quality services of excellence to be provided for women and children in this center. And if I have time later, I will respond to Dr. Layton. Let us conclude this presentation to your excellent question.
My name is Fang Yu, registered midwife, working at a diversity midwife in Scarborough area. Conclusion, in summary, we support the proposal for the Center of Excellence in Maternal, Newborn, and newborns and women's health at the Toronto Scarborough Hospital, Richmond. An integrated model of patient-centered care provided by a multidisciplinary team of healthcare professionals working together with community provider will ensure safe and timely access to quality care. So we respect and look forward to the expert advice of this panel to help Toronto Scarborough Hospital move forward to provide excellent, safe, and access care to meet the growth need of this diverse midwife.
Thank you very much for your presentation. Pass that question.
Just one question, Dr. Chang. You said you had input from frontline healthcare workers. I don't see anywhere here anesthesiology, and I don't see anywhere here the ICU support addressed that would
Yes.
be required.
As I said, some of them cannot be present right now, but they will be doing another presentation. For the surgical department, Dr. Ramovich will be addressing these concerns because they were originally going to present in this, join us in the presentation, but due to time constraints, they're going to do their own presentation in the afternoon later in the day, and especially to address the concerns of Dr. Lehman, because the question was excellent because there was a lot of support for the Center of Excellence at the Birchmount for maternal newborn. But then you see a lot of doctors that signed a petition against it. It was that we cannot understand taking away the complex surgery and inpatient beds. That will not help with the Center of Excellence. So there was a kind of a contradiction there. That was why there was so much physicians upset and community upset that we do need the surgical support. So Dr. Brownbush is going to address those concerns. And in fact, I actually thank the administration because the original plan was to close, there are only 30 beds, like there's only one surgical floor at Birchmount and 3 surgical floors at the general site. So you see there's only one surgical floor with 30 beds in North Scarborough compared to 3 floors in South Scarborough. So basically, if you close 25 beds and leave only 5 beds, we cannot support a Center of Excellence here. So the administration actually has responded to a lot of our input, and they have decided not to close these 30 beds at this point. And of course, they look forward to the expert advice of this panel to let them know what they should do with the surgical plans in order to provide surgical support for the Center of Excellence here.
That's great. Thank you very much.
First of all, is there the interpreter interpreter here available today? We did request one for.
Yes, we do.
Could I ask the interpreter to come up, please? So I want to switch a little bit from certain higher level issues to patient preference. And one of my midwife colleagues actually highlighted about patient preference. And my topic today is about the large population that we serve here in Scarborough, and that is our Chinese mothers. I want to preface this talk by basically saying that I have strong ties to the Scarborough community. I moved here to the Adrian Court area in the mid-'80s, and my family still lives here. So I am basically in no way putting down the Grace campus or the Birchmount campus at all in this talk. I mainly want to just highlight what many patients have expressed, and this is their opportunity to speak if they wish to speak. However, we do have also emails that I would like to present. Is it possible to move the screen projector over a little bit? It's just cutting off. Okay. So just a few questions to start off with. Does it make sense to move birthing services to a hospital where many patients do not want to go to deliver their babies? Does it make sense to move where many obstetricians don't want to practice? And I speak on behalf of many of my colleagues at the General, myself as well. And I wish to say that if there is a move to integrate birthing services at the Birchmount, I personally will not go there. Touching on the topic of conflict of interest, as a declaration, I can say that I'm not making this presentation to protect my own practice, because I can move my practice, and it certainly will not be to the Birchmount. So does it make sense to take a higher volume obstetrical unit with greater support services and move it to a place where there are lower volume of deliveries with less support services? The big issues here are that many Chinese expectant moms believe that the Birchmount campus is a poor choice to have their babies at. Is this a relevant question? I think it is, because despite all the talk about money and what services we deliver, patient preference is very important. Is this reputation deserved? That can be debated. Should you care? I think all of us should care, and we should really pay attention to the following emails. Should moms be forced to go where they don't want to go? I don't think so. So here is the first letter that we've received. By the way, are there any moms who wish to speak today on this issue? Okay, great. So you want to come on up? We'll give you a chance in a minute. So, thank you for coming. So the reason we've had an interpreter is because some of our patients are not very confident with English, and having an interpreter was greatly appreciated. So some of the wording in some of these emails may be a bit strong. I have not edited this in any way. I have highlighted certain points which I just want to draw your attention to. So I'll just go ahead and read some of these emails. Dear committee members, as a pregnant woman, I don't agree that Grace Hospital will merge with General Hospital. I told my family doctor that I can accept any hospital except Grace Hospital. 2 medical accidents happened at that hospital. The young mothers died after having a baby. I don't want this kind of worries through my whole pregnancy. I'll move ahead. Hello, my name is, I'm a patient of Dr. Larissa Tan, assigned in the Scarborough General Campus. I want to skip to point 4 here. There has been some unfortunate deaths of the mothers at the Grace campus, and no mother would like to deliver their babies there anymore. Point at the bottom, overhauling services at the Scarborough Hospital could put patients at risk and cause doctors to quit. The hospital's board has been warned. Another email. I oppose the unification between Scarborough General Hospital and Scarborough Grace Hospital for the following reasons. Point highlighted, I deeply believe that the Scarborough General Hospital has better service and better doctors than Scarborough Grace. Again, I'm not putting down Scarborough Grace. These are opinions expressed by the patients that we serve. There are 3 reasons I would like to support my OB, Carol Penn, against the merge of Scarborough Grace and General Campus.
Members of the panel for dedicating your time to hear us, and the comments you heard are quite compelling. My name is Stephen Jackson. I'm a general surgeon. I've been a surgeon at the Scarborough Hospital for 20 years, and currently I'm the corporate chief of general surgery. I prepared this presentation representing 14 general surgeons across both campuses of the Scarborough Hospital. I'm going to restrict my comments basically to the original proposal that pertains to the changes in surgical provision of care in the strategic plan refresh. Our group has carefully examined the proposed changes in terms of how they would impact many aspects of care. We examined the impact as well to the surgeon's practices. We looked at the quality of care, patient safety, efficiency, and effectiveness, and we clearly understand the financial drivers for the proposed changes and understand that many of the recommendations flow from the previous commissioned Hay report. The plan aims, as you very well know, to differentiate the Birchmount campus into an ambulatory care surgical center where only elective outpatient surgeries are performed during the day. The operating rooms would close after 5 p.m. The general campus would concentrate on more complex surgery that would require overnight hospital stays, and any patient arriving at the Birchmount campus emergency department with a surgical problem that either requires urgent surgery or admission to hospital would require ambulance transfer to the general campus. There are many concerns raised by this arrangement. Based upon historical data, the number of patients that would require stabilization and transfer for emergency surgery would be over 300 per year. And in addition, there are at least that many number of patients that would require urgent admission and transfer for non-operative surgical care. While most of these patients would be stable enough to tolerate the treatment delay associated with this kind of a transfer, the most acutely ill would likely suffer from such delays. And with an active intensive care unit at the Birchmount campus and an active internal medicine wards, there would certainly be patients that require general surgery consultation and some requiring urgent surgery, as you've already heard. This would require the transfer of some of the most acutely ill patients and the most unstable of patients. Even with the ability to perform the occasional emergency procedure at the Birchmount campus, surgeons would have to provide post-operative care for these patients at the Birchmount campus while they're also looking after their own inpatients at the general campus. This would require significant fragmentation of care, where one surgeon may initially assess a patient in the emergency department or the ICU at the Birchmount campus, only to then transfer care to another surgeon at the general campus. Literature has shown that there is always a significant increase in risk to patient safety with each and every transfer of care. The risks associated with this scenario must be considered in the setting of an acute care hospital within the borders of the City of Toronto. We're not talking about a small community, and I don't know what the population of Kitchener-Waterloo is, but is it 600,000? 600,000, so similar to Scarborough, but Scarborough is not a standalone community. We are part of the 2.5 million population of the City of Toronto. And while the expected standard of care in a small rural hospital may include many patient transfers, this is not the case in an urban environment in a hospital with a purported full-service emergency department. And I stress that point. We're talking about two full-service, or purported to be two full-service 24/7 emergency departments where one doesn't have the ability to perform emergency surgical care. Beyond the issue of patient safety and risk, one must also consider the inconvenience and stress placed upon all the patients and their families when a transfer is necessary. Confusion, uncertainty, and anxiety would add to the understandable duress patients and their families experience. With the population demographics of Scarborough, further travel may be an added burden placed on those who are already vulnerable. General surgical services are an essential support for the safe operation of a full-service emergency department. We strongly feel that in order to safely service two 24-hour, 7-day-per-week emergency departments, the capacity to adequately treat general surgical emergency patients is an absolute requirement at both campuses. This implies having the ability to perform urgent surgery at each site over the full 24-hour period and the ability to treat post-surgical inpatients at each site. It's crucial to clearly understand the consequences and risks associated with the proposed plan. It should be stated that these changes do not enhance the quality of care as compared to the status quo. We ask that the expert panel carefully consider the risk to patient safety that would result from this plan weighed against the potential financial benefits. That's all I have. Thank you.
One of the anesthesiologists at the Birchmount campus, and my name is Dr. Neil Jaminsky. I'm one of the anesthesiologists at the general campus. We felt it would be important for us to present this today so we can demonstrate that the Department of Anesthesia is pretty much unified in our opinion as to what needs to and should not be done. So I'm going to pass the microphone over to Dr. Malik, and she's going to present you with a slide.
Good afternoon. First of all, thank you so much for your time. I'll begin. As Neil had said, I'm going to be presenting our view as a department, combined Department of Anesthesia, in terms of the future of the hospital, the Scarborough Hospital. I thought I would begin by going through some of the rationale that I went through when deciding to work at Scarborough. As Dr. Irish will attest to, I'm one of the newer members of the department. I've been with the department for about 5 years. And 5 years ago, there was a plethora of anesthesia jobs. And I worked at 7 GTA hospitals, but I chose to come to Scarborough. I chose to come to Scarborough because of the diverse, vibrant population, that was often very challenging to me, and also because of the exemplary staff. And it's been an honor and a privilege to work at the Scarborough Hospital. The reason that we're presenting this deputation to you today is that the proposals that are set forth, the ones affecting maternal, newborn, and child care services, as well as the ones affecting the surgical services, we as a department, and I'm representing 25 anesthetists, feel this jeopardizes patient care and patient safety. This is why we're here today. As you all know, the Scarborough Hospital is one of the largest community hospitals in Canada. We have 2 campuses, and we have 2 very, very busy emergency departments. The Birchmount campus, which is smaller and less equipped, still sees about 50,000 emergency visits per year. The general is closer to 70,000. When you have emergency rooms that are that busy, you need to have integral programs, your core essential services at both sites. And we in anesthesia define those as being general surgery, obstetrics, pediatrics, internal medicine, and anesthesia. When we look at the proposal about citing maternal, newborn, and childcare services at one site, there's been no precedent for OB consolidation in a community hospital. The examples thus far have been in an academic hospital that's comparing apples to oranges. The Scarborough Hospital, unlike academic centres, is situated in a densely populated residential area. We have a large number of people that we serve that rely extensively, access the services that are provided at each site.
I would just like to point out that a number of the patients that we've been told, both pediatric and older, do rely essentially on the hospital emergency rooms for their care. They either don't have family doctors or don't realize that there's certain services that they can receive from family medicine. And often they just either that or they're too busy, becoming new Canadians or working or to try to earn a living, because we do live in a poor immigrant community where we practice. And essentially, these are the patients that come to see us quite late when they're quite sick. So we want to make sure that we have the services available to them.
There's also the issue of loyalty. We have patients who go to the general site primarily that will not migrate to the Birchmount campus, not just for adult issues, but it's a financial thing that's not easy to get from one site to the other for financial reasons, and vice versa for the Birchmount campus. This has implications for funding, where it's going to be related to where patients are according to the new funding formula. That has detrimental effects for our future as well. Just a specific note about pediatrics and obstetrics at the Birchmount campus, where my practice is primarily. North Scarborough is, like other parts of Scarborough, is growing at a record rate. I also happen to locum at North York General. It's surging at the seams. It's not going to be able to keep up with all the growth in North York and North Scarborough area. We from a location perspective, are in a unique position to be able to capture the deliveries from that area. The other thought that's come to our mind is that when you look at consolidation, it requires significant capital investment. As a group, we feel that the analysis has not been fully completed. The true cost of consolidation, including capital investment in infrastructure, has not been looked at or is not realistic. So whether this is truly going to be a cost-saving measure, we're not sure. The other issue is when you're thinking about citing an obstetrics and pediatrics program at one site, regardless of where it is, whether it's one-sided or two-sided, you need general surgery backup to deal with the emergencies and complications. That's something that we can attest to firsthand. The current proposal, which looks at short stay or day surgery at the Birchmount and inpatient or complex surgery at the general site, doesn't take that into account.
It completely ignores the realities of maternal newborn care in a very big, very diverse community where patients do tend to present sicker, where patients don't speak the English as a first language, where we have a lot of patients that don't have proper primary care. So we want to make sure that when trouble happens, that we can provide them with the best care that we can, and that includes having general surgery, operating room backup, proper operating room nurses with backup, proper ways to stop bleeding, especially postpartum hemorrhage. I'm sure you've probably heard all about that today. And we don't feel that the administration has adequately addressed these concerns, other than saying we'll just put the patient in an ambulance, which we think is a very substandard way of doing things.
So moving on to the surgical procedure, surgical proposals. When we look at the proposals that have been put on the table, we as a group do not feel that this is going to work out. Like as mentioned, we have two extremely busy emergency departments that are to be open 24 hours a day, 7 days a week. We cannot maintain those emergency departments without the possibility of providing emergency inpatient surgery. There's no precedent of this in the Greater Toronto area. In my practice within the past year, I've had a significant pediatric airway obstruction where a 5-year-old boy came with a grape stuck in his trachea. If we weren't able to take that child into the operating room immediately, that child would have died. As a parent, as an anesthetist, I would have no leg to stand on. I wouldn't be able to face those parents. I've had a massive GI bleed or gastrointestinal bleed in a patient that needed 20 units of blood, hemodynamically unstable. The question of transfer would not have been possible. I've seen ruptured ectopic pregnancies. I've seen perforated viscus. This is one anesthetist out of 25. If you multiply these kinds of cases by 25, it becomes clear we don't have the luxury of time or proximity to transfer these patients, and we need to be able to manage life-threatening conditions at both sites. Other general problems plaguing these proposals. is primarily that there's been no, since the day Birchmount campus opened, there's been no investment in infrastructure. The infrastructure at the general campus is crumbling. Our ORs there are over 50 years, 2 minutes, over 50 years old. When you're talking about transferring, increasing patient loads, again, these implications of these changes have not been looked at. The associated costs have not been analyzed. Again, whether it's really going to save money, we don't know. The other important issue is that there are physicians who have practices that have been ingrained around their hospital for over 20 years. They base their practice around their main hospital, and they're proud to work at these hospitals. By asking them to move between sites that are not in close proximity, you're looking at possible physician fatigue, affecting clinical decisions. It's going to lead to low morale. You're going to have difficulty in retaining the excellent physicians that we have thus far and in recruiting any new physicians. We've had some excellent surgical programs. We've lost those programs. We're just going to continue to lose.
The last point I want to make before we have to wrap up is the wonders with communications and Blackberries and iPhones. We found out this morning, the Department of Anesthesia, that we were falsely represented at your committee this morning. You were told by one of the members of the administration that the reason why you have to merge obstetrics to one campus and rob them of surgical services was that so you can quote-unquote anchor anesthesia. That was not that has never been presented to the chief of anesthesia, and you will have a deposition on your table saying that because he's already submitted it, and I have a copy of it. That is not the view of the entire Department of Anesthesia because we've pulled them today. So we don't know where the administration basically found that information from because it is completely fabricated and otherwise not accurate.
And just quickly, in terms of something has to be done. We understand we can't stay status quo. We have to look at other ways. We have to look at innovative ways of bringing funding into the hospital. There's some great ideas, but no one has elicited them from the staff. We need to consider the closure of non-essential programs that are very expensive to the hospital, and this has been a recommendation that was made before. An example of that is a spine program, which has nothing to do with maintaining a 24/7 emerge. I guess the bottom line is thank you.
Second of all, I'm not sure that as much as it's the council that we have much as it's you myself
Well, we were told this morning you were presented with a question from the panel that why was the administration so intent on locating MNCC at Birchmount? And you were told that basically so that we can anchor anesthesia, so that we can keep anesthesia at the Birchmount, and that isn't true. The Department of Anesthesia is committed to supporting both campuses 24/7, no matter where obstetrics is, and our ultimate preference would for it to be at both campuses so that we can have wide, diverse practices, so that we can be busy when we're on call, so that we don't just sit there and do nothing all day long in either a non-busy obstetrics unit or a non-busy surgical unit. And we frankly don't like being misrepresented. Again, would you like me to do that right now, or? Okay. Okay. We just don't want the committee to go away thinking that the whole reason why all these changes have to happen is because of the Department of Anesthesia. That is not true. Well, that's not one of the reasons, essentially, that they would offer. It's 14 at 1 and 11 at, yeah, our chief floats between both sites. Not really. Sort of. No, not really.
No,
No.
Winston takes care of
Yeah.
that.
We do what's called cooperative independence. So in other words, we cover the calls. Each group covers their own calls, but we will cover each other's site if the need arises. And we've never had any trouble doing that. Any member. We go back and forth all the time. Sure. Well, I can answer it too.
I think we have a very cohesive nature when it comes to our departments, and our priority is patient care, patient safety. And so as a group, we would, it's just up until now, it's been very easy to have two separate departments that are considered one whole department. But if the need was to arise for us to work together and work between both sites, there'd be no objections from anybody in our group.
But then when we looked at the volumes that we'd be doing and what call would be like, we never thought that it would be a good idea to split obstetrics and surgery. Basically, you would have one anesthetist covering after hours and weekends and holidays, a place where they have to stay because there's obstetrics and there may or may not be anything to do. The volumes will definitely decrease. That's well known. That's been presented quite a bit this morning. The volumes will definitely decrease. And the other department, essentially, the other place, so supposing it's at Birchmount, the obstetrics, and then in general, we won't have any luxury of having a pediatrician available. And stuff does come through the emerge occasionally, and we do occasionally get kids that are quite sick, and we know that they're planning on calling us to basically cover this, and we don't feel comfortable with treating very sick children at all. And we don't want to be responsible for that. It would make for a very poor working environment. It would make for basically a group of anesthesiologists at both sites that feel that they've been getting the short, that they signed up for this and they're getting the short end of the stick. It doesn't make for very attractive departments in either site at all. No, definitely not at the general if it lost obstetrics. And I don't know about Birchmount. Do you think in-house would be sustainable?
Very difficult to say. If obstetrics comes and we lose inpatient surgery, probably not.
And we'd like to know that, we'd like to, one last point, mention that we were never ever asked these questions. I prefer that there be other ways to find changes to the status quo than eliminating very important services from either hospital. That I think my department would stand behind very proudly and support. Go ahead.
I think it comes down to dollars and cents. My husband is a surgeon at UHN. They have very innovative ways of bringing funding, external funding, outside of Ministry of Health funding. Some of those ideas can apply to the Scarborough Hospital. We've been asking for the opportunity to speak about that. We haven't had that chance. There's inefficiencies. You need to talk to not just the physicians, but the nurses, the pharmacists, the physiotherapists, the team attendants on how to save money and provide more streamlined programs. None of that has been investigated. I touched upon inequality in terms of programs that are expensive and costing the hospital. We need to look at what we can do to maintain the 24/7 emergers. We serve a population that is not as vocal as other populations. There's a lower socioeconomic status, many immigrants, many sicker patients. We need these services, and we need them at both sites.
We need to sustain services and potentially even grow them at both hospitals. We understand the financial realities of Ontario. We know there's trouble right now. We, as a department, and we will be getting a deposition from our chief agreeing that we don't think this is the way to go.
Just for information,
How big is your obstetrics program?
It's
That's 3,000. We're roughly 3,000 at one site and 2,000 at the other site. So. Mhm.